My name is Brandy Holcomb, and I am a adult geriatric acute care nurse practitioner student with the University of Texas at El Paso, presenting a case study for Nursing 5361 regarding a patient with a ground level fall. Mr. CWB is a 90-year-old male patient that has presented to the emergency room via EMS for evaluation of a reported ground level fall last night. The patient's daughter-in-law has accompanied the patient to the emergency room, and as she and her late husband are Mr. CWB's primary caregivers. She is at the bedside. She is considered a good historian and gives an account of the events from last night and early this morning. She states that the patient fell last night around 8 p.m., hit his head on the tile floor. She says that he did not appear to lose any loss of consciousness. Location of the impact was to the left temporal area that also has a laceration above the left orbit. She states that the patient was self-ambulatory last night. She accounts after he went to sleep there were no events that she is aware of. She accounts that this morning she went in around 9:30 to wake the patient up, as sleeping late is out of the normal for this patient. She noticed that the patient had difficulty getting out of the bed and noticed some left-sided neglect. She states that the laceration above the left orbit had continued to bleed so much so that it bled through the dressing that she had applied the prior evening. Mr. CWB has a history of chronic atrial fibrillation is on warfarin for anticoagulation. He is managed by Dr. Sheldon Freeberg with Trinity Clinic Cardiology. His INR initially on presentation to the ER was 3.5. He has a GCS of 15. The patient himself denies nausea, vomiting, and incontinence. Patient did display left-sided weakness and neglect. His clinical exam and diagnostic workup by the emergency room physician revealed a right temporal hematoma that measures 2.5 by 2.2 centimeters on head CT. Trauma surgery has been consulted for admission and management of this patient. Past medical history is significant for atrial fibrillation, cerebral vascular accident, frequent falls, urinary retention due to benign prostatic hypertrophy. He has a chronic indwelling catheter for urinary purposes. He would be admitted to the trauma ICU. Past medical history includes atrial fibrillation, CVA, hypertension, falls, urinary retention, benign prostatic hypertrophy, peripheral vascular disease, hyperlipidemia, arthritis, depression, and skin cancer. Past surgical history is a right carotid endarterectomy in 1997 and left inguinal hernia repair in 1984. The patient is allergic to Flomax. His home medications are Carvedilol 12.5, BID PO, Benadryl 25 milligram capsule every 6 hours as needed for itching. He takes a ferrous sulfate 324 milligram enteric coated tablet daily by mouth, furosemide 40 milligram tablet PO daily as needed for leg swelling. Lisinopril 2.5 milligram tablets, one by mouth daily, multivitamin PO daily, potassium chloride 10 milliequivalents continuous release capsule as needed with Lasix, simvastatin 20 milligram tablet PO at bedtime, a vitamin D 3 supplement BID by mouth, and warfarin 5 milligrams PO daily. Family history for this patient. Patient's family parents are both deceased. His mother had type 2 diabetes and congestive heart failure, and his father passed away after a substantial battle of colon cancer. Health promotion, Mr. CWB is up to date with his influenza and pneumonia vaccines. Social history, this patient is a widower. He also recently lost his only child, a son, to a terminal illness last week and is currently dependent on his daughter-in-law for his daily care. He denies ever being a smoker, and he drinks 1 4-ounce glass of red wine daily with supper. Review of systems. Constitutional, he is 90 kilograms, height is 76 inches, positive for activity change. Positive for left eye disturbance, negative for right eye visual changes. Neurologically, positive for dizziness, positive for headache. Cardiovascular, negative for chest pain and palpitations, positive for syncope. Respiratory, negative for shortness of breath. Gastrointestinal, negative for nausea and vomiting, negative for melena in his stools. Urinary, positive for frequency, urgency, and incontinence, negative for any known odor. Vascular, negative for extremity swelling. Musculoskeletal, positive for weakness, primarily on the left side. Skin, positive for easily bruising. On physical exam, the patient was found to have vital signs of blood pressure 126/81. He was in atrial fibrillation, 97 beats per minute. Respiratory rate was 24 respirations a minute. Temperature 98.5 degrees oral. He was 98% on room air. He appears to be deconditioned. Appears anxious and distressed. Positive for left-sided neglect. Head is normocephalic. Hair distribution to scalp is even without thinning. Color is white. Positive for left periorbital edema, left conjunctival hemorrhage. Pupils are equal in size and react to light. Positive for left visual neglect. His ears are symmetrical. The auricles are in alignment with the outer canthus of the eye, or excuse me, of the eyes. No drainage. There is minimal serum. No lesions or foreign bodies in the external ear canal are noted. Tympanic membranes are pearly gray in color without perforations. No erythema or and bony landmarks are visible. Nasopharynx mucus was pink without septal deviation. Buccal membranes are pink and moist as well. His neck is supple. Trachea was midline. The thyroid was not palpable. Jugular vein distension is not noted. Carotid upstrokes were strong without bruits. No swelling, no nodules are palpated. Neurologically, his mental status, he is alert and oriented with a Glasgow Coma scale of 15. His chest, a noted thoracic expansion, is symmetric. Breath sounds were clear to auscultation with noted diminished breath sounds in the bilateral bases. Cardiac, PMI impulse is noted to the 5th intercostal space left of the midclavicular line. Regular rate is unappreciated. The rate is irregular to auscultation. S1 and S2 are normal, no murmurs. However, he is positive for irregular rate and rhythm. His abdomen is non-distended. Bowel sounds were present to auscultation in all 4 quadrants. The spleen was non-palpable. The abdominal aorta was clear to auscultation with no bruit. Urinary-wise, Foley catheter is in place, draining to a leg bag. No penile discharge is noted. Vascularly, no cyanosis or clubbing is noted. No edema. Brachial, radial, femoral, and popliteal, dorsalis pedis, and posterior tibialis pulses are palpable, strong bilaterally. Musculoskeletal, there is no erythema or warmth to the joints. His skin is warm and dry, no rashes. Positive for a 3 centimeter temporal laceration. positive for right parietal contusion, noted bruises to bilateral forearms, no skin or nail lesions are appreciated. The assessment and plan: Mr. CWB is a 90-year-old male with a history of coronary artery disease, atrial fibrillation, and Coumadin anticoagulation. He is a status post ground level fall last evening, presenting with a traumatic brain injury with right intracerebral hematoma, left-sided weakness, and neglect. We would admit this patient to the trauma intensive care unit. I have consulted Dr. Andrade with neurosurgery. Neuro checks will be performed Q1 hour, and nursing staff has been informed to notify Dr. Andrade with any focal changes. We will stop warfarin now. Pharmacy consultation for the use of Kcentra. His INR is 3.5. Immediate anticoagulation reversal with Kcentra with a target of INR of 1.3. For this INR, we will administer 25 units per his weight of 90 kilograms for a total dose of 2,250 units infusion of Kcentra. Serial PT and INR will be performed 1 hour post Kcentra infusion. The patient will be NPO except for his medications. We will restart his home medications at Carvedilol 12.5 milligram tablet, BID with meals. We will continue his ferrous sulfate 324 milligram enteric coated tablet with breakfast. Lisinopril 2.5 milligram tablet, PO daily. We will continue his multivitamin, PO daily. Simvastatin 20 milligram tablet, POHS. Vitamin D3, PO BID. Ultram 50 milligram, PO Q6 hours PRN for pain. Nursing has been informed to call for unrelieved pain or headache. PPI for stress prophylaxis, we will use Protonix for 40 milligrams PO daily. Normal saline 0.09%, 100 cc's an hour IV. Keep his blood pressure less than 180. Call for blood pressure greater than 180. We will start him on bowel prophylaxis, Docusate sodium 100 milligrams PO BID. We will repeat a head CT this evening at 1800. I have ordered a bedside echo for in the morning with Trinity Clinic Cardiology to read. The indication is history of atrial fibrillation and patient is a status post ground level fall. Local wound care for laceration. Cleanse the laceration with saline soaked gauze. Keep covered with sterile gauze dressing. Consult to wound care nurse. We will change out his urinary catheter and place a catheter bag with a urimeter. We will put the patient on fall precautions. He is to be bed rest with bathroom privileges with assist to the bathroom, no self-ambulation, as his patient is a high fall risk. DVT prophylaxis with bilateral SCDs, low molecular weight heparin is contraindicated at this time. I have discussed the patient's status with the patient and the patient's daughter-in-law. The patient has let me know that in the event that he is unable to make critical decisions, his daughter-in-law is to be his medical decision maker. At this time, this patient is a full code. I would like to thank the emergency room staff and Dr. Williams for giving us the opportunity to collaborate in the care of Mr. CWB. Thank you.